at Andreassen's data, even without good. This is another extreme case, same type of approach, an extensive fracture below the level of the interdental papilla. So we prepped the buccal and proximal aspect as if the tooth was intact for traditional veneer. Then we rounded off all transition line angles. And one thing I want to mention here, for good aesthetic result, this transition line angle with the incisal edge between the facial aspect and the incisal edge, this edge must be rounded off very carefully, because if you leave an acute angle here, the dental technician will have a hard time assuring the transition, a smooth transition in the opacity of the porcelain. And that's very important. Mechanically, we know that this is the strongest design we can do. And please believe me, I am not the one who invented that. It was showed by Andreassen 15 years ago, that when you build up the missing part of the incisal edge and you use an adhesive technique in the form of a porcelain veneer, like this one on the right, you are actually stiffening and reinforcing the tooth significantly. And Andreassen did his studies while dentin boning agents were not able to fulfill a good adhesion here. However, today we have a better way to proceed. But look at Andreassen's data, even without good bonding agents to dentin. This is a compilation of a bunch of studies he published in the early 90s. And he could show that in a load to failure, the strength of the restored tooth, every time you place a veneer, the red part, every time you place a veneer, you make the tooth stronger. And even stronger than the intact original unrestored tooth. So now the question is, how strong is strong enough? But for sure, a veneer is acting as a reinforcement. And especially when you have a large bulk of porcelain like that. So I know some people are very skeptical about this, but I want to tell you, the thicker the porcelain, the stronger it becomes. And it's like having a glass plate in your hands. If the glass plate is 1 millimeter thick, you can break it between your fingers. If the glass plate is 1 inch thick, you are not able to break that in your hands. And that's the exact same reason why these thick incisal porcelain veneers are extremely resistant. And it acts almost like a beam, a reinforcement beam in the coronal portion of the tooth. And in this case, you see another absolutely magnificent work of Michel using the refractory dye technique, a full thickness layering. Look at the transition between the freestanding part of the porcelain and the part of the porcelain that is supported by the tooth. It is invisible. Why? Because Michel used a large amount of opacious dentin to build up the inner part of the tooth and then the more translucent layers. This is the most exciting indication, I think. You see a comparative view. What is the difference between these two pictures? Mainly time, baseline versus 7-year follow-up on this case. And you see the very mild changes, mainly at the level of the gingiva because of the maturation of the gingiva. But 7 years later, you see the image here, everything looks exactly like day one. And I cannot say that with other techniques like crowns or like composites. Only bonded porcelain restoration give you this picture of long-term stability in function and aesthetics. You see the palatal margin at 7 years, very little changes, no infiltration, a little bit of surface staining here on the lingual, but very little things to say. Can we do the same in mandibular teeth? Absolutely yes. You will have the same amount of strengthening that you have on upper teeth. Lower teeth are always a little more delicate to restore because they are thinner, they are smaller, But fractured teeth like this one are better restored by veneers than by crowns, because we know the dramatic effect of a full crown preparation on the biomechanics of the remaining tooth substance would have in the lower teeth. In this case, that was exactly the similar approach. Is a 4-year result. We also use veneers at the upper teeth on the centrals, lateral, and canine on this side. Now, this is a little bit the end of spectrum of what you can do with these techniques, and I want to be a little bit thought provocative with this case, and I want to tell you what I want to reiterate what I said at the beginning. When teeth are vital before we start, they should stay vital and at the end of the treatment. And this is why I like to show you this case, because these teeth are really survivors. They have survived the many generations of composite restorations that were applied. Only one of them died here and has a root canal treatment that we will redo, of course. But all others are still alive. And I tell you, in this condition, my recommendation is really to prep only the facial aspect for veneers and restore the palatal aspect with composite as much as you can. Now, we have technique to control shrinkage. We have build-up material that are non-shrinking, like glass ionomers, like self-curing composite, like Adaptic can be used as a base material to restore the main dentil volume on the palatal, and then the surface with aesthetic light-curing restorative composite like here. Fix the palatals first as much as you can. In this case, the endodontically treated tooth was just armed with a little titanium post. That's it. And then we'll wax up the facial aspect of the teeth, and we'll do a mock-up, and then we'll prep according to this mock-up. And when we prep these teeth, we just ignore the fact that there is composite already on the tooth. Only on the central incisors we have removed almost totally the composite, because we could include that in our preparation. And you see now the volume that was left, the amount of porcelain that will be used. It's quite significant, but everything was placed adhesively. And we have a typical type 3 porcelain approach in the central incisors, a perfect indication. The case is a full mouth rehabilitation that needs much more other work needed, as you can see, but we wanted to start with the anteriors because I was leaving for Los Angeles. It's still a case I did in Geneva, and at this moment I could only start with the anteriors, and the rest had to be done at a later stage. You see the x-ray of this case. It's really my favorite pictures, is the before and after, and you see the amount of tooth substance that was maintained, the vitality of the teeth that was maintained, and this is for me of paramount importance. Almost any other treatment modality would have led to the loss of pulp vitality, which of course we could avoid, and a very happy patient, as you can imagine. So to conclude this description of the spectrum of indication, as you guessed, there is not a type 1, one type 2, one type 3 restoration. It is a combined indication. Most of the time we combine indications. This is the best example. In this case, excuse me, you have tooth number 9. 21 would be for everybody using the international numbering system, right? Not here in the US. So tooth number 9 is not responding to internal bleaching. There's spaces the patient wants to close. We have incisal length to be augmented because, as you can see, there's no cohesiveness between the incisal edge contour and the lower lip line. And for all these reasons, we are going to use bonded porcelain restoration. As usual, the case is mocked up, is waxed up, mocked up, and you see here the silicone index of the wax up guiding the incisal reduction for later, but showing you that we really fit the contour of the lower lip. The preparation on the facials after doing these preparations, and the final result after the placement of these 4 restoration, a typical combined case. Again, a general view with the face of the patient before and after. So now I want to go a little bit through some procedures, and I want to tell you that every single case was mocked up, and the preparation technique we use is really using the mock-up as a guide for tooth preparation. So every time I have a situation like this is a case of erosion, I would start by doing preliminary impressions and ask Michel, my brother, a wax-up. Then I would take very specific silicone indexes like you see here, and I would etch the facial enamel, rinse and dry, and use acrylic resin over the teeth molded by the silicone index. Then you can very easily finish the excess. The acrylic is usually let to set completely in the mouth so that it's completely retained, and then the excess are cut away with a burr or with a scalpel. Now sometimes if you are afraid of doing that, you can section the silicone index around the cervical contour of the teeth so that the excess of resin, and this is a basic acrylic polymethyl methacrylate provisional resin that we use. You can remove the excess around the teeth before the resin is completely set without removing the silicone index. It's very important to leave the silicone index on the teeth until it is completely cured, until the resin is completely cured. And then we are going to use glazing resins and light curing stains to finish the surface by just glazing, applying some colorants in the proximal, and light curing using an air block, an air barrier to assure the final curing of the surface. And you will get very quickly, and there's a significant learning curve. But I tell you, when you start doing these mock-ups with acrylic resin and with staining and glazing, very quickly you will see it is a lot of fun. It's the most fun part of the treatment. You see another case, just after removing the silicone index, the resin is completely cured on the teeth. It remains in the mouth while you trim it, you finish it, you glaze it, you stain it like that. And you get a very appealing, very pleasing aesthetic outcome for the patient to test. Now, sometimes you need some preliminary tooth preparation to do the mock-up, especially when the dental technician did a reductive procedure using the wax-up. In this case, of course, you need to prepare a little bit the teeth to allow the space for the acrylic resin. Otherwise, the other steps are the same. I'm using a resin called New Outline that you can find in Europe through Anaxdent, in the US through Microstar Corporation. This is a nice resin because it has actually, it's a basic polymethyl methacrylate, so it's very soft, it's very easy to work with. You have dentin shades. I recommend you only to use dentin shades when you do mock-ups and provisionals. It's better for the aesthetic outcome, and you want to take care to always choose a dentin that is one shade lighter than what you want to reproduce, because the glazing process, due to the camphor quinone in the glazing agent, is absorbing a little bit of the brightness. So if you want to get an A3, you need to fabricate your mock-up or your provisional with an A2, and after glazing it will turn A3 actually. The glaze called skin glaze is included in the kit here, and it is a very ultra low viscosity glazing resin. You cannot do the glaze with your bonding agent, for instance. It's not going to work, it's too thick. Now, once the patient has tried and approved this mock-up, and I tell you it can be 2 weeks, or it can be 2 days, it can be also 2 months. The patient is instructed how to floss around these restoration. The contact point is not broken, as you can guess, so the patient can use only the super floss to clean around the teeth. But if you instruct the patient correctly, the mock-up can stay in the mouth for months if needed.